Morning. We are still in Cameroon. This is still just about 11 o'clock. So good morning to everyone, and for our friends in South Africa and East Africa, good afternoon. It's good for me. I'm happy to be sharing this short discussion with you, our Cleft partners. This is the outline that I'm going to take. I know that there are people interpreting. I hope that I will be slow enough for them to be able to interpret. Normally I speak very fast, but I will try to be quite slow. That said, we're going to talk about the role of the ENT surgeon in comprehensive cleft care. And as you will see at the end of this presentation, that the ENT surgeon has a lot to provide. So this is the outline. We're going to have an introduction. We're going to talk extensively about otitis media with effusion, which is very common, which is something that has been understated, which affects a lot of cleft children. And then we'll talk about otitis media with otitis media, chronic suppurative otitis media, and velopharyngeal insufficiency. So children that are born, so to begin with, cleft lip and palate is a congenital orofacial anomaly, and it causes a lot of psychological stress to both the family and to the patient. And as we all know, the patient is going to undergo a series of operative procedures over the course of time. So, and even though to the layman, the palate and the ear are far away from each other, children with cleft palate have a higher incidence of ear infection. And with the ear infection comes difficulties with hearing. And since children learn how to speak by hearing, you will understand with me that a child that cannot hear well will have difficulty speaking well. And we are going to be having this discussion we're going to discuss about conditions that are commonly seen, conditions that are ENT conditions that are commonly seen in patients with clefts. We're going to look particularly at otitis media with effusion and eustachian tube dysfunction, acute otitis media, chronic suppurative otitis media, and we'll talk a bit about cholesteatoma and adenoid hypertrophy, and lastly, we'll talk about velopharyngeal insufficiency. Acute otitis media with effusion is very, very common in children with cleft palates. And studies have shown that close to 90% of children with cleft palate will develop acute otitis media with effusion, or rather otitis media with effusion, before the first birthday. And by their second birthday, 97% of children will have had otitis media with effusion. And the reason why these children are prone to developing otitis media with effusion is essentially because of three reasons. The first one is because of the immature development of the eustachian tube. In children, the eustachian tube is shorter, it is more horizontal, and has a larger angle of curvature. And that makes it easier, or make the children to be more prone to having otitis media, and particularly otitis media with effusion. But more so in children that have cleft palates, because of the communication between the open communication between the mouth and the nose as a result of the cleft palate, there is recurrent inflammation of the throat, and that inflammation predisposes the opening of the eustachian tube to be blocked, and that leads to stasis, infection, which subsequently leads to otitis media with effusion. There is also abnormalities in the muscles associated with the eustachian tube. When somebody has a cleft palate, the muscle attachment of levator villi palatini and the tensor villi palatini is distorted. So that gives abnormal functioning of the eustachian tube. And of course, last but not the least, because of the cleft palate, there are abnormalities in the hamulus and the medial pterygoid plates, and that leads to children with cleft palate to be having recurrent ear infection. Even though acute otitis media with effusion is often overlooked because it doesn't really cause symptoms of discomfort, but for parents that are very attentive, you will discover that these children might be having, they will tell you that the child is not hearing well, and they will have to shout before the child notices anything like that. So normally these children will present with mild to moderate hearing loss. There is delayed cognitive and speech development, essentially because children have to hear to be able to learn how to speak. So if children do not hear or speak, then they'll have difficulties learning how to speak. That leads to delayed speech development and delayed cognitive development. And these are subtle clinical signs that some mothers will be able to pick out and they will complain, particularly for mothers that have more than 2 kids. They'll be able to compare that, look, my first child did much, much better than this one. And those are signs for you as a clinician to know that the child may be having some difficulties with hearing. So if we suspect that this child has difficulty with hearing, there are ways that there are things that we can do to ascertain the diagnosis and then initiate appropriate management. We have the first thing to do is otoscopy. You can do, for people who have experiences, even with the normal otoscope, you can pick otitis media with diffusion. But the pneumatic otoscope, you will look at the middle ear, you look at the ear, and when you apply the air in the ear, you will discover that the compliance with the tympanic membrane is reduced. So that will give you a high suspicion in a child with otitis media, in a child with cleft palate, that they may be having otitis media with diffusion. You can also use a telescope where you look at the ear and the images are displayed on the monitor. You can also use, you can do a tympanometry. Tympanometry, you put a probe in the ear, it sends sound wave into the ear, and it measures the compliance. And most of the time, a type B tympanometry will be indicative of otitis media with diffusion. And in more advanced setting, you can do what we call spectral gradient acoustic reflectometry. You give wave to the ear, and the reflection from that tympanic membrane is measured by a machine, and that is it's a 5 seconds procedure. And the reason why this test is more advanced or is more accurate is because you don't have to, because some people have difficulties examining a small child, a child that is less than 1 year. But with spectral gradient acoustic reflectometry, it is an easy and straightforward test, and it gives better results. Once you have been able to establish, normally on an examination, this is what you see on your otoscope. You can see that tympanic membrane, even though in some cases it may not be as reddish as this one is, but you can see fluid behind the tympanic membrane. Normally, this fluid behind the tympanic membrane is actually sterile fluid. So when you make this diagnosis, the modalities of treatment are pretty controversial. And there are some people who say that we shouldn't do anything. And that is what I generally do. I don't do anything. You just watch, because up to 90% of children that have acute otitis media, I mean, suppurative otitis media, between the ages of 3 to 4 years, the thing will resolve without you doing anything. But of course, there are those who believe that something has to be done, particularly if you re-examine the child after 3 months and you discover that the hearing loss is getting worse, or there is significant or impaired speech development in that child. Then there's those who advocate that we should insert a ventilation, a grommet tube. And so you can either do watchful waiting, or you can prefer to insert a ventilation tube. In some settings, particularly in the Western world, a ventilation tube is inserted at the time when the cleft palate is being repaired. And people who are advocating that ventilation tube should be inserted say so because even after you have repaired the cleft palate, the incidence of otitis media effusion does not reduce. So it is studies have shown that this child will still go ahead to have recurrent episodes of otitis media with effusion just before they reach the age of 12. So those who think that we should insert a ventilation tube, that is the reason why they say so, you know. And when you insert your ventilation tube, that is what it looks like. So acute otitis media is also very, very common in children with cleft palate. And the reason, as I've said before, they have a more horizontal and short eustachian tube. And because of the recurrent inflammation of the throat, or of the throat, of the nasopharynx, because of the cleft palate, there is blockage of the opening of the eustachian tube. And because of that blocking, there is stasis of secretion in the middle ear, which leads to infection. And studies in Africa, studies in the Western world have shown that the commonest organism associated with this is Haemophilus influenza and strep pneumoniae. Even though studies have been carried out in Zaria, which talk of Staph aureus instead and E. coli. And we know, and it is also documented that acute otitis media is usually preceded by an upper respiratory tract infection. Like we've said, because of the open communication between the mouth and the throat, these children are prone to upper respiratory tract infection, eventually leading to acute otitis media. And I've said before, the commonest single etiological factor, important factor in the etiopathogenesis of acute otitis media infection is the obstruction of the eustachian tube. And as I've previously alluded, why the tube is obstructed. When you do your ear examination, this is essentially what you see. And the treatment of otitis media, acute otitis media, is pretty simple. You give them amoxicillin. If you give amoxicillin and after 5 days the child is still febrile, then you can go to augmentin. From augmentin, if you are not getting good report, then you may need to give ceftriaxone. So the treatment is subdivided into first-line antibiotics and second-line antibiotics. And in some cases where you are giving your antibiotics and you are not satisfied, particularly in neonates, you may need to go ahead and do a laryngotomy. You make an incision on the tympanic membrane and drain the pulse. But in children that have recurrence, pretty recurrent occurrence of acute otitis media, a grommet tube insertion may be indicated. Chronic suppurative otitis media is usually a sequelae of acute otitis media. And the bacteriology of chronic suppurative otitis media is quite different from that of acute otitis media. And the commonest pathogens that have been isolated are Staph aureus, E. coli, and some anaerobes. And usually when you do your examination, there is perforation of the tympanic membrane. Most of the time you have a central perforation, but you can equally have marginal perforation, total perforation, you know. And if you look well into the canal, into the middle ear cavity, you are going to see that there is intense inflammation of the middle ear. And we know that if this chronic suppurative otitis media is not appropriately managed, this can go on to give you cholesteatoma. And for the layman, or if you say that you want to describe what a cholesteatoma is, it's not really a tumor, as the name is alluding. Cholesteatoma is essentially skin in the wrong place, skin in the middle ear. You see wools of shells of skin in the middle ear, which is cholesteatoma. Cholesteatoma has the possibility to destroy bone, and it can lead to meningitis or a brain ulcer if not properly managed. And I will say, when you look in the middle ear, there's lots of granulation tissue, and you may have cholesteatoma. And the management of chronic suppurative otitis media is that you need to give topical antibiotics, quinolones topical antibiotics. That is the standard treatment of choice. You give ear drops, which you put in the draining ear. You first of all clean the ear and teach the patient how to use cotton bud to clean the ear or cotton wick to clean the ear. After you clean the ears, then you can instill drops of quinolone, ciprofloxacin, or what we commonly in our environment we use Cetrasal Plus, which is ciprofloxacin ear drop. You give it twice a day, morning and evening, and before you instill it, you instruct the patient that they need to clean the ear before they instill the ear drop. And that is done for between 1 week to 10 days. When the ear becomes dry, then we normally do a pure tone audiogram to assess the hearing level of the child. After the hearing level of the child is assessed, then we go ahead and we do tympanoplasty. I won't go into the details of how tympanoplasty is done, the types of tympanoplasty. But basically, tympanoplasty is that you are trying to repair the perforation that is in the middle ear. And most of the time when you do that, you prevent the recurrence of infection, and you also prevent the complications that are associated with chronic suppurative otitis media, which is cholesteatoma, brain abscess, and facial nerve paralysis and all the like. So that is why we do a tympanoplasty. But I must reiterate here that when a patient has recurrent chronic suppurative otitis media, the reason why we do a tympanoplasty is not necessarily to restore the patient's hearing loss. The main reason for us to do a tympanoplasty is to prevent the complications that come along with chronic suppurative otitis media. And in most cases, in more than 92% of instances, when you succeed in achieving that, then there is improvement in the hearing of the child. And if you are able to catch the complications of chronic suppurative otitis media, which is cholesteatoma in this case, because children with cleft palate because they have a higher incidence of chronic suppurative otitis media, they also tend to have a higher incidence of cholesteatoma. In fact, cholesteatoma is 100 times more frequent in children with cleft palate. And the treatment for cholesteatoma is mastodectomy, which could be cortical mastodectomy, canal wall mastodectomy, or radical mastodectomy. You know, this is what you see for a child in a case of chronic suppurative otitis media. This is after the canal has been cleaned. You can see the canal, the tympanic membrane is reddish there, and you can see a central perforation there. So in this child, after the cleaning of this canal, after the cleaning of the ear, we give ear drops, ciprofuscalizing ear drop for like 10 days, and then before we can be thinking of doing the tympanoplasty. So why do we spend so much time talking about ear infection or otitis media with effusion, acute otitis media, chronic suppurative otitis media, or cholesteatoma in a child that has cleft palate? What are the consequences of this in this child? The consequences are pretty important. And if this is not properly managed, then this will cause a lot of problems to the child in future. Like I've said before, 90% of children with cleft palate will have otitis media within the first year of their life. And because of that, and if that is not properly managed, 50% of them will go ahead to have some form of conducting hearing loss. So it is very, very important for us that when we see these children, we make an effort so that they can be assessed by the ENT surgeon so that acute or recurrent ear infection can be treated so that we can prevent some of the complications that come along, particularly for otitis media with effusion, which are atelectasis, ossicular chain fixation or ossicular chain discontinuity, tympanosclerosis, cholesteatoma. The effect of the four of these conditions that I've mentioned is that it causes conductive hearing loss, and it can cause as much as 30 to 60 decibel conductive hearing loss if it is not properly managed. And we know if this conductive hearing loss is not properly managed in a child, particularly between the ages of 3 to 6, then the child cannot learn speech well, because children learn how to speak by hearing us speak. So if the child is not hearing well, the child cannot be able to speak well. And we also know that if this child is not hearing well, when the child goes to school, the performance will not be good. And that means that if the child cannot have adequate education, good education, then the prospect for that child growing up and fulfilling all his potentials are greatly reduced. So that is why it is very, very important for us to take this seriously. And the child will also, in addition to conductive hearing loss, the child can also have sensorineural hearing loss. It's been documented that because of recurrent chronic suppurative otitis media, which is a condition that is common in children with cleft palate, you have sensorineural hearing loss as a result of toxins moving from the middle ear through the oral window and the round window into the cochlea, and this leads to sensorineural hearing loss. And because the child cannot hear well and cannot hear or speak well, there is normally delayed or impaired speech development. So you can see that the consequences of a child not hearing well, the child with cleft palate not hearing well, are quite enormous. And that is why it is very, very important for us who see these children, who manage these children, to be able to refer or take appropriate steps so that these common conditions that affect the ear can be appropriately dealt with. So the other condition that is quite common in children with cleft palate is what we call velopharyngeal insufficiency. Between the nasopharynx and the oropharynx, in normal people, there is what we call a velopharyngeal valve. There is a circle of muscles that is formed when you look at the muscles of the soft palate and the muscles of the lateral wall of the palate. They form a velopharyngeal valve, and that valve play a very important role in the production of some sound during the process of speech. So if, like in the case of cleft palate, we know that there is a defect in the muscles of the soft and the hard palate. That valve does not function inadequately. So these people have issues with production, with speech or production of certain sound. And that is why it is recommended that cleft palate should be done as early as possible, because if you don't do them from the ages of 1 year to about 10 years, then that speech cannot be adequately corrected, except now you have to do it and send the patient to the speech and the language pathologist to work with the patient. And in the African setting, we know that most of the time we don't have these services. So it is good to aspire to do your cleft lip and your cleft palate surgery before the ages of 10, so that speech cannot really be affected adversely. So velopharyngeal insufficiency is defined as inadequate closure of the nasopharyngeal airway port during speech. And it is, we are saying that regardless of the technique that is used in the palate closure, up to 50% of these children will develop some form of velopharyngeal insufficiency. It can be mild, it can be moderate, it can be severe. That in most cases will necessitate a second pharyngeal surgery. I know that maybe at some point we had a discussion with the speech and language therapist, and he talked about this. But I think it's important as an ENT surgeon that we have an idea of what this. And how do we investigate a patient that has velopharyngeal insufficiency? You can do video fluoroscopy. It's when to radiographically examine the upper airway with the aid of an oral contrast agent. Normally, you do this. The ENT surgeon does this with a speech and language pathologist. They will give this contrast to this patient to swallow, and radiographs are taken and they're assessed. And you can also do a nasopharyngoscope, which is something that we do in the office very recurrent when we're investigating patients that have nasopharyngeal tumors or adenoids. When you do this, when you look past the nasopharyngoscope through the nose, you look at the postnasal space, you look at the adenoid, you look at the palate, and you can look at that. Those videos, those pictures are put on the monitor. And you do that most of the time in conjunction with the speech and language pathologist. The reason why you do that is so that you can study the effect of your palate or the effect of the palate repair on the speech of the child. And when you do that, you assess the palate. Well, I'm just looking at, I showed this picture here for us to see how the velopharyngeal valve is formed. This is the normal anatomy of the velopharyngeal valve. You can see your tensor villi palatini, levator villi palatini, palatopharyngeus, palatogrossus. Those are the most, and the posterior pharyngeal wall. Posterior pharyngeal wall made up of the superior constrictor predominantly. Those are the muscles that make up the nasopharyngeal, the velopharyngeal valve. And in cleft palate, these muscles are disrupted, as you can see in this diagram. Because these muscles are disrupted, that valve mechanism is disrupted. So there is problem in the production of certain consonants during speech, and that leads to velopharyngeal insufficiency. And that's when the speech and language pathologist come in, and the ENT or the surgeon comes in. And following your video fluoroscopy and nasopharyngoscopy, the closure pattern of the esophagus is documented. It can either be a coronal closure pattern, which is in 55% of normal people, and it can be sagittal, which is in 10%, 10 to 15%, and it can be secular. After you have documented this, after you have carried out these tests, you and the speech and language pathologist, you can now come out with a plan on how to correct the velopharyngeal insufficiency. You could decide that the speech and the language pathologist will work with the patient and see how you can do proper pronunciation of those part of speech that are affected. Because you must remember that even after you have corrected the cleft palate, when you correct the cleft palate, you don't correct the pattern of contraction, you don't correct the nerve supply. So after you have corrected the cleft palate, some form of velopharyngeal insufficiency will still persist. And after you have assessed them, there may be need for follow-up with a speech and language pathologist, or there may be need for a second palatal surgery, which is to correct the velopharyngeal insufficiency, where you can raise palatal flap, superiorly based, inferiorly based, or you use the anterior or posterior pillar of the tonsil. So the management of various pharyngeal insufficiency is essentially by the speech and language pathologist, where he works with the patient, or surgical, as I mentioned. So it is something that we need to be aware and look at, and that this, for the child to have comprehensive cleft care, this has to be looked into and corrected. And lastly, I want to talk about adenotonsillar hypertrophy in children with cleft lip and cleft palate. Children with cleft palate, particularly, can also develop adenotonsillar hypertrophy. And this is very, very important for us to realize, and it's very important for the ENT surgeon to know, because children that have some form of, children that have submucosal cleft, and in some children that have mild or moderate velopharyngeal insufficiency, that can be obscured by adenoid hypertrophy. When you, as an ENT surgeon, goes and does the adenoid surgery, then you make this insufficiency to become more apparent. So it's important for us to have it at the back of our mind that it's very possible for these children with cleft palate to have velopharyngeal insufficiency. And further, it's also important for us to know that they can also have adenotonsillar hypertrophy, and that when you remove the adenoids, it can make the velopharyngeal insufficiency to become more apparent or worse. So if you do not have that at the back of your mind and counsel the patient appropriately, then they may accuse you that it is because of the surgery that you did that this obscured velopharyngeal insufficiency has become apparent. For that reason, it's important for us to know that patient with adenoid hypertrophy, that adenoid hypertrophy can conceal some mild form of velopharyngeal insufficiency. And if you don't know that, if you want to remove all the adenoids, then the mild form of velopharyngeal insufficiency can become moderate or a severe form of velopharyngeal insufficiency necessitating surgery. For that reason, it is recommended that for children that have some mild form of velopharyngeal insufficiency, when you want to take care of the adenoid, you take only the anterior part of the adenoid. You don't take the posterior part, because that posterior part helps in making the velopharyngeal insufficiency less apparent. The same thing can also happen for patients with tonsillar hypertrophy, because it can conceal or it can make velopharyngeal insufficiency worse. And so we need to know that, so that by the time we're doing tonsillectomy, we make sure that we do not remove the anterior and posterior pillar, because those anterior and posterior pillar are part of the things that are used when you want to correct velopharyngeal insufficiency. I hope that I've not been too fast for my interpreters. I tried to speak as slowly as I could. Those are my references. Thank you very much. Back to you, moderator.
Thank you very much, Dr. Acha, for this comprehensive and very educative presentation you have made. I think it has shown the importance and the role of ENT in a comprehensive care. And I think this is why we are having this teleclass series, for us to know the roles of the different specialists as we move towards comprehensive care. And I want to thank you that you have done real justice to justify your seat on the table as part of the comprehensive thing. Thank you very much for this beautiful presentation. We want participants to send their questions to the Q&A. But before the question starts coming in, I want to find out, in Cameroon, what is your role? Do you have a team? And how do you participate in the team? Is it an interdisciplinary or a multidisciplinary team that you have? And when do you really come in? Do you come in early or after the palate surgery is done?
Well, I think I've just, like you said, I've just succeeded to say that the ENT surgeon has a role to play in the multidisciplinary cleft team. Like you introduced before, I'm a cleft surgeon, and Smile Train had helped us to train some of our nurses to do some form of speech and language therapy. I, as a person, when patients are born, I am in the northwest part of Cameroon, which is the English-speaking part of Cameroon. So when patients are born, they know where my hospital is situated, and they know that we do cleft surgery. For now, our team is very limited, in the sense that I am an ENT surgeon, I'm the cleft surgeon, I have an audiology technician, and I have somebody who does some speech, who has done some minimal speech and language therapy. So when I do the cleft surgery, to do the assessment of the ear in my department, we clearly do it in my department. and we follow up those patients. And like I said in my presentation, most of the time, there's really no need for us to put a groomed tube, because when we fix the cleft palate, these children, we have been doing this surgery now for 9 years, and we have watched a lot of the children that we have operated grow to become teenagers, and some have gone to the university and are doing pretty well. So we have not had need to do groomed tube. I think I've done groomed tube only for about 2 cleft patients. But in terms of the speech and language pathology, we're very limited. And we have not done surgery for insufficiency. I think I've done just one. So we've not had that. But I think we've not done that per se. But I think we've had children that have velopharyngeal insufficiency that we have worked with our speech pathologist, and have had good improvement. I don't know if I've answered your question.
Yeah, thank you. You've answered my question. I want to find that, because now you have a dual role. You have a role as a surgeon and also as an ENT. What do you think is the ideal role of an ENT? Is it as a surgeon, as an ENT surgeon, or to focus mostly on these ENT issues and leave the surgical review to the plastic or maxillofacial?
Yes, honestly, if you discuss with Nicole, she follows me all the time. I think the reason why some of us do this cleft surgery is because we don't have enough cleft surgeons per se. Because as an ENT surgeon, I am a very, very busy fellow as an ENT surgeon. We don't even have enough ENT surgeons in Cameroon. So just the ENT work is very, very much for me. But I do cleft surgery because in my part of the country, we don't have enough cleft surgeons. That's why. But I think that in a setting, the ideal setting should be that the cleft surgeon should take care of the cleft, and then we should be able to take care of any ear-related issue. I think that is a standard.
Thank you very much. Because
that should be where we are heading to.
Yeah, we have a team in Kano, and I'm privileged to have an ENT surgeon with me, and he's focusing purely on the ENT aspects. He is not part of the surgical team that repairs. But the surgical aspect we're thinking that he should focus on is the VPI, velopharyngeal insufficiency. So that I think with his expertise in that region, I think he will be more effective in providing that expertise and that specialist care in tackling that, especially working also with the speech pathologist. Or what do you think?
Yeah, that is a standard. I mean, when we have specialized care, if we can have cleft surgeon, I will be very happy only to wait. And the patient is referred to me to look at the ear-related issues, which is something that I really love doing. I really love taking care of the ear. And if there are issues to do a second palate surgery, we are very, very willing to do. But I think for now, because we don't have enough cleft surgeons in this part of the country, in fact, not only in this part of the country, in the whole of Cameroon, because I receive children that are born in Yaoundé, in Douala, who come here for us to do so the issue is that we don't have enough cleft surgeons. And I think that our partners, Smile Train, as they're listening to us, they will know exactly what to do so that we can encourage younger people to train as maxillofacial surgeons, to train as cleft surgeons, so that me as an ENT surgeon, I can concentrate on the ENT aspect of the work.
Thank you very much. Finally, I want to find out from you, what should be the protocol? What should be the timing of intervention? First assessment by ENT and subsequent follow-up. What do you think the ideal intervention time should be?
Well, like I said in my presentation, there are quite a lot of controversies, but what we do in my setting is that the child is born with a cleft palate or a cleft lip and a palate. We are informed of this child. Maybe they call me and they talk to me over the phone and whatever. We are most of the time when that call comes in, we want to know whether the child has a cleft palate, because that is a more damaging part of this congenital malformation. If the child has a cleft palate, we will advise them that they should send the child to our hospital, because all hospitals around us that have nutrition counselors. So they come to the hospital, the nutrition counselor counsels them. And if everything goes well, by the age of 3 months, they are already more than 5 kilos. So at that stage, we are able to do the cleft lip. We normally do cleft palate surgery from 9 months. And The reason from 9 months. But me, if we by 6 months, we begin to look at the ears. Because I must tell you that look into the ear of a neonate is not, it's pretty not easy. Or to carry out all the video fluoroscopy and all the things that I talked about. It's not pretty easy, but we do it. So we recommend that for groomed tube, you can insert a groomed tube from the age of 1 year. If you are planning to insert a groomed tube, then you need to wait until the child is 1 year, so that at the same sitting, when we are doing the cleft palate, we insert a groomed tube. But otherwise, which is still something that is not pretty easy for those little tiny ears. So that's what we do here. And I think I've done for like 2 or 3 patients, if my memory is still good. And then we follow up those patients, because when you put a groomed tube, the groomed tube will be in normally under normal circumstances between 6 months and 2 years. The groomed tube will fall out. And for those who you keep monitoring them, if they continue to have recurrent otitis media, the recommendation is that you should still insert another groomed tube. That's the recommendation. But if you assess the patient and the hearing loss is not significant, it's mild, it's negligible, then you just follow up the patient. You don't need to insert a groomed tube, which is what we do for a good chunk of our patient. But like I said, it's quite a controversial topic.
All right, thank you very much. Finally, what advice would you give SMILE-trained in terms of building up the capacity for comprehensive care and the ENT aspects, and the type of equipment and facilities and capacity that needs to be developed? So that we look at it and say, okay, for each country, at least we should be able to develop a center or 1 or 2, depending on the size of that and the load of cares we have. So that if we are advising them as an ENT specialist, what advice will you give in terms of facilities that needs to be provided and in terms of training that needs to be provided for the ENT to be able to provide the specialist care that is needed?
Prof, thank you for that question. We've spoken a great deal with Nicole and with Mrs. Obi. For me, I think that, first of all, since I know a little bit of Nigeria because I studied in Nigeria, there should be a center of excellence. SMILE-train, if it's possible, SMILE-train should have a center of excellence in the southwest and the southeast and in the north. And then in a place like Cameroon, we have SMILE-train has like 10 partners in Cameroon. We can create a center of excellence in Cameroon, where we have an ENT surgeon, we have a speech and a language pathologist, a center where all of what is needed to give comprehensive cleft care can be provided. Because, like I said, it is not all the children that have cleft palate that we need all of these services that I was saying. But we need a center where other peripheral centers, if they have such, they can refer them there, and that comprehensive cleft care. So SMILE-train need to provide more training. We need to have more cleft surgeons. There was a time that they talked of a training in Ethiopia of the speech and language pathologist, and we are very excited because that was going to come to fruition, so that we can send some of our nurses to go and have an in-depth training to do the speech and language therapies. Because I don't know, maybe speech and language therapy is well developed in Nigeria, but in my own part of the country, we don't really have. I think in Cameroon, as of now, we have only 2, and they are quite far away. And we know some of these patients are poor. So when you do the cleft surgery free, to send them to some of these to go and meet these speech and language pathologists, they won't go. So my recommendation would be that we should create the SMILE-train as much as they can to have centers of excellence where they have all of this package are situated, and that patients from peripheral health centers can be referred there so that they can have the full package.
Thank you very much. I think questions are not coming in because most people are just listening to you and they don't even have the opportunity of working with an ENT surgeon before. And I think that's why we have very few questions. But there are a lot of commendations about the quality of the presentation, the information and the capacity you have developed, and the education you have provided with this, your presentation. It has been well received, and everybody, there's a lot of congratulatory messages on the chat and this thing. Thanking you for this wonderful presentation. I've really personally enjoyed it because I'm privileged to have an ENT and a comprehensive team in Kano with me. We have an orthodontist, we have an ENT, we have pediatrician, we have the whole team, so that I can appreciate what you're talking about, and it's really been beneficial. And I think what we really need to do is to start documenting our experiences and start publishing them, especially as you are talking about these otitis media and other conditions that they have. I even wanted to find out the tympanic perforation. What do you think is responsible for this?
Well, the commonest cause of tympanic perforation is the recurrent infection. You know, children with cleft palate are really prone to recurrent infection. So what chops off the tympanic membrane is essentially infection. And that's why we think that because I said chronic suppurative otitis media is a sequelae to acute otitis media and otitis media with effusion. So the commonest cause of perforation is infection. And these children are prone to infection. That is what causes the tympanic membrane to be perforated.
Thank you very much, Dr. Acha. You have really educated us this morning, and everybody is impressed with this. And those who do not have an ENT, we appreciate the role of ENT in the comprehensive care of cleft care. So once again, on behalf of the West African College of Surgeons and Spine, I want to thank you for this illuminative presentation. And now I hand you over to Nico. Thank you very much.
Thank you, sir.
Thank you so much, Dr. Acha. This presentation is not just educative and illuminating. I think it's even for the staff. We have really benefited from your experience and your model of work. And then, as you said, we should have a college of a site of excellence to be able to really add all these components to our team. So thank you so much for opening another door of opportunity, and so that we can step in to bring all these solutions that to all these problems that you have mentioned. I also want to thank all the participants, our panelists, our staff, and everyone, and also very big thanks to the college who has been very supportive we're doing this through Professor Adebola, who is always present with us and standing by us. So I want to welcome everybody once again for tomorrow's session, and hope that you invite more people, because it's getting very, very interesting this month. Thank you. And I'll see you tomorrow, same time.
Thank you.